Hi, everyone. Good evening. This is Catherine in Boston. Thank you for joining the NATF online support group. It's 7 o'clock, so we're going to go ahead and get started. I am delighted to introduce everyone to Dr. Brett Carroll, who is a vascular medicine fellow at Brigham and Women's Hospital and has also been actively involved in starting a pulmonary embolism response team, which is what he's here to speak with us about tonight. So, Dr. Carroll, if you want to go ahead and take it away.
Thanks so much, Catherine. Welcome, everybody. I'm excited to join today. My first time with NATF on the support group, but I think it should be hopefully an insightful hour or so. So I'm just going to go through a little bit of what a pulmonary embolism response team is. As Catherine said, I'm currently a fellow of vascular medicine at Brigham and Women's Hospital, briefly a cardiology fellow at Beth Israel Medical Center in Boston as well. And while there, I started a pulmonary embolism response team. So to start off, I'm just going to present a case that was very instructive to me when I was early on in my fellowship at Beth Israel, and kind of brought on and spawned my enthusiasm for starting a PE team. So as a fellow, I was called to the emergency room to see a 63-year-old gentleman that had about a week of shortness of breath that was getting progressively worse. And he had noted that when he really pushed himself on exercising, he'd been short of breath for a couple of months, actually. He was worried because his brother had died suddenly in the last previous year or two. And when I saw him in the emergency room, he looked quite well, as he had normal vital signs and normal lab work. He had an EKG, which this doesn't mean much to many of you, but there were some abnormalities that were concerning for a possible blockage in one of the arteries supplying blood to his heart. So he was admitted to the cardiology floor with the plan for either a stress test or a cardiac catheterization, where we look at the arteries around the heart. But fortunately, when he got to the floor, he had an ultrasound of his heart. And you can see where the arrow is pointing. That's an abnormality. That shouldn't be there. And that's a big blood clot going in and out of the right side of his heart. This was clearly unexpected for my initial assessment and concerning. So the next step was to get a CAT scan of his chest to verify that he had a pulmonary embolism, which again, you can see the red arrow there. There is a blood clot of one of the big pulmonary arteries that supplies the lungs. So when we saw this was very concerning to a lot of people, but we had to start calling around because it wasn't clear to us the next best step to take, because this was a relatively rare but very concerning finding. So we called the general cardiology attending, who called the cardiac ICU attending, who then called the cardiac surgeon. And this all took 3 or 4 hours because there was no point person to help manage pulmonary embolism. So we finally went to the operating room to help with the goal of pulling out that blood clot that we saw in his ultrasound. Unfortunately, by the time he got to the operating room 4 or 5 hours after his initial diagnosis, and you can see this is another ultrasound, the blood clot is no longer there. So unfortunately, in that delay of 4 or 5 hours, although it was necessary to mobilize everybody, given the current systems that were available, the patient sustained the pulmonary embolism. Fortunately, he did quite well. He received clot-busting medications and was discharged a few days later. And this is now 3 or 4 years ago, and he's doing quite well to this day. But it was this case that brought on my idea in my prior experiences in training to form a pulmonary embolism response team. What we found is there's a lot of heterogeneity in PE management between different services. That being said, a patient may go to the medical ICU or the cardiac ICU or a surgical ICU. Depending on what ICU they're in, may get very different management. There are growing management options for pulmonary embolism. These have been developing over the last 5 to 10 years. So now we have more sophisticated means of treating pulmonary embolism than we had in years prior. But with that is varied choices in management styles depending on what hospital you're at and what part of the hospital you may be in. And at least at Beth Israel Deaconess Medical Center at the time I was there was no clear service that could urgently assist in complex PE patients, as we saw demonstrated in that last case. So what I wanted to do was meld the ideas of a rapid response team and a multidisciplinary team being that of many specialties coming together as one to manage pulmonary embolism. The general idea of a rapid response team has been around for 15, 20 years, And you need an afferent limb, and that's just a fancy word for a recognition limb, someone to find the disease, in this case, diagnose a pulmonary embolism. And then you need a system in place to activate the efferent limb, and that's just the limb, in this case, which is a pulmonary embolism response team. And although it seems simple enough that once the diagnosis is made, a team should be able to be activated, unfortunately, the complexities of a hospital don't necessarily make that as easy as would be hoped. So, like I said, the rapid response team idea has been around for 15 or 20 years. It came out of the manuscript called It's Human, which many of you may have heard back in 1999, which shed a light on many medical errors that were occurring by physicians and others in the healthcare field. So studies have been done in the last couple of years showing that with the development of rapid response teams, these teams were for very sick patients that were in the hospital. They found a 12% decrease in hospital death when a rapid response team was available. That's just a group of doctors and nurses that were specialized in taking care of sick patients that were on the floor. And they found a dramatic, almost a third decrease, a little more than a third decrease in cardiac arrest when a team was available. So this idea of a rapid response team has been around for a bit, but not really for pulmonary embolism. This was just a study back in 2012 that showed that there's a quite high mortality in pulmonary embolism when a patient is unstable. So that is someone that has a low blood pressure or other concerning features like requiring a breathing tube or even having a cardiac arrest. Mortality is very high, as you can see, 32%. And the majority of those can be attributable to the pulmonary embolism themselves. And the other reason that a rapid response team may be beneficial for PE is because those patients that do die from a PE half of them die within the first 3 days of being there. So often these patients can come in very sick, and when they do, they can get sicker in a short manner. Therefore, a rapid response team is necessary. And this is a complex slide that isn't meant to be fully appreciated, but it's a complex mechanism of how patients get sick with a PE. But what happens is that the right ventricle, which is the side of the heart that pushes blood into the lungs, gets very sick when there's a pulmonary embolism because now it's trying to push blood up against the blood clot. The right ventricle isn't made to push the blood up against any type of obstruction like that. So what can happen is this rapid deterioration where a patient may be more in this orange color and be relatively stable, but as they wrap around, they can be very quickly become sick into cardiovascular collapse or cardiac arrest. This is where we want to catch patients before they start to get into that orange period and certainly before they get into that red period. So in the case of a rapid response team, the afferent limb are those providers that are making the diagnosis off the emergency room, but it can be a primary care physician, an urgent care clinic, or even some patients that are already admitted to the hospital. And then there's the efferent limb, which is a PE. PE, as many of you know, is a multi-system disease process. It involves the lung, the heart, the coagulation system, the blood system. So depending on what institution a patient may be at, there's a variety of different specialties that are listed there that may take care of a patient with a PE. So what we want to do is to meld these different specialties and to form one team. Our goal is to optimize the risk stratification and management of increasingly complex patients with PE. We wanted to make sure that the utilization of new treatments were available to all patients and were being appropriately used because some of them had side effects. So we didn't want to overuse them, but we wanted to make sure the patients that may benefit from them were at least having the option discussed. We wanted to improve the cognitive interchange between different specialties within the hospital to make sure that specialists within hematologists understood what a cardiologist was thinking or what a pulmonologist was thinking when making a decision about a patient with a PE. We want to learn from each other, and certainly our goal is to make more efficient coordinated care for sick patients with a pulmonary embolism. So this idea of a multidisciplinary team has been around for a while as well, just not within the field of pulmonary embolism. There's something called a heart team, which has been advocated by the guidelines, the big groups of cardiologists that decide what may be the best treatment for patients. Feel a heart team, which is the involvement of a cardiac surgeon and multiple specialists within cardiovascular disease to decide the best care of patients that have complex needs, whether it be blockages in their heart or valve disease or heart failure. This isn't just limited to cardiology. There are stroke teams that are multidisciplinary that involve interventional radiologists and neurologists, And there are tumor boards for patients with complex cancers that involve medical oncologists, surgical oncologists, radiation oncologists. So this idea isn't foreign to medicine, it's just foreign to pulmonary embolism, or had been. So this slide is only meant to show that there are a lot of different options depending on how a particular patient presents with a pulmonary embolism, whether they're stable or unstable. We go down a different algorithm. And within each category, there are a variety of different tools we can use. So the first part is just making the diagnosis, which can be very tricky at times, and the team can help when there's a pulmonary embolism is suspected. Again, we assess the patient for their comorbidities, if they're high risk for bleeding, if they have underlying heart disease or lung disease. And we use a variety of tools, CAT scans, ultrasounds of the heart, blood biomarkers that could show elevated risk of having a pulmonary embolism. And we use that as a team to discuss if there may be benefit to doing some of these more advanced, though sometimes risky procedures. So here's just a list of the variety of different treatment options we have for patients with pulmonary embolism, from the relatively straightforward of thinning the blood with anticoagulation to the very complex of something called ECMO, which is like a cardiac bypass that's used during open heart surgery, and then a lot of options in between. And you can see, depending on what the particular option may be, there are different specialists within the hospital that may be experts within that particular field. So rather than the traditional consulting scheme where the primary team, whether it be the emergency room or the ICU team, would call all the individual specialties and then wait for a response from every individual specialty, and then often what would happen is the hematologist would make a recommendation that may differ than the pulmonologist, but then the primary team has to decide which one may be quote-unquote right, or the best avenue to take for the patient. So rather than having all these individual opinions and then having the team trying to figure out what may be best, who may or may not be the experts at the time in pulmonary embolism, we try to streamline that. So once a pulmonary embolism is diagnosed, the PE team is consulted. We have a conference call with all the specialists that have a particular interest and expertise within pulmonary embolism, and they come up with a uniform plan and a coordinated, efficient, implementation of a plan for a patient. So the primary team is no longer getting multiple different opinions or stories. They're getting one coherent opinion of how best to treat the patient. So what we really have done is meld the rapid response team that was developed for sick patients on the inpatient floor, and then the multidisciplinary team, as we've learned from treating patients with cancer or complex heart disease, and combine those two to form a pulmonary embolism response team. So this is the name of the team that we developed at Beth Israel Deaconess Medical Center. There are a variety of different names depending on the institution. We have an acronym called Massive and Submassive Clot on Call Team, Mascot. Easily recognizable name for the emergency room, the ICUs, the floors, even outside hospitals within our network can call the Mascot team whenever they feel that there's a sick patient with a pulmonary embolism. You see the variety of different specialties that are part of our team. The way our team works, and many others, similar to here at Brigham and Women's Hospital, once the Mascot team is consulted, the on-call fellow, the cardiology fellow, will see the patient in person and decide where in the algorithm they may fit. If they're on the higher risk side, they'll call in via a text chain of members of the team to bring everyone together to alert them that there's a new patient that needs some assistance. Once that's done, a web-based conference call is set up and a plan is implemented. Here, this is just an example of a paging system that we use at Beth Israel. So anyone in the hospital network can just type in Mascot, and they'll get the direct person who's on call for the team. They can also, down in the emergency room, they just have a button they can push. So it's pretty simple. It says pulmonary embolism, and a page goes directly to the team. So if someone is sick, it's a kind of rapid onset activation of the team. This is an example of our web sharing conference call system. So everyone signs into the system similar to how you did today. And we screen share an ultrasound or a CAT scan if necessary, and we can all talk about the patient over the phone. So again, to coordinate care as best as possible. And because often these patients come in overnight at 3 a.m., it's tough for everyone to run into the hospital at 3 a.m. especially when there's 4 or 5 experts that are available. So we try to get everyone together quickly, and this allows us to, fortunately, with new technology. So quickly, I'll go over a second case of where the team, after the team was implemented, that was very, I find, helpful, and I think did well by the patient. It was a 75-year-old gentleman that was undergoing spine surgery. He had several weeks of immobility prior to his surgery because he was in so much pain he wasn't moving very much. During the surgery, his blood pressure dropped all of a sudden and got everyone very nervous, the anesthesiologist and the surgeons. They did an ultrasound of his heart that showed strain of his right ventricle. As we discussed, that's what can be impaired in the setting of a blood clot in the lungs. Because of this, the surgeons finished up quickly. He immediately went to the CAT scan room and got a CAT scan, which showed very similar to our first patient, a large blood clot on the right side of his lungs there in the pulmonary artery. So the team was activated. We had a call with all members of the team. So the cardiologists were involved and agreed that the patient was sick because of his low blood pressure and that something should be done urgently. But because of his recent surgery, there was concern about giving him clot-busting medication, which has been the tried and true therapy for decades. The hematologist had concerns about giving him a blood thinner given the recent surgery as well. The cardiac surgeons weren't excited about taking him to the operating room, given he had just undergone a big surgery and had concerns about his ability to rehabilitate from an open heart surgery after a big spine surgery. And the pulmonologists were a little concerned about his breathing at the time. Fortunately, we had the interventional radiologist on the call who had heard of a new catheter, which is just a fancy word for a long, skinny tube that they have used previously for strokes. He had used it several times in PE at his former institution. So here, this is a still frame of an X-ray video where the interventional radiologist put the catheter into the lungs and sucked out the clot. This, unlike many other mechanisms we have for treatment, did not involve any blood thinning and did not involve any clot busting, which everyone was worried about for bleeding in the spine given his recent surgery. So the interventional radiologist was able to suck out a fair amount of the clot, and the patient's blood pressure improved dramatically. So this is just a review. This is actually going back a few months ago. This is the first 72 patients seen by the PE team at Beth Israel Deaconess Medical Center. And this isn't meant to show the statistics, but it's meant to show that we're collecting a lot of information based on these patients. And we're up to 120 patients at Beth Israel, and there's over 300 patients at Brigham and Women's Hospital since the teams have been implemented over the last couple of years. We do a variety of different treatments, and we try to use this information to learn to optimize treatment for the next patient that we hear about. We recently had our data published from Beth Israel Deaconess Medical Center in the American Journal of Cardiology. And again, this is to inform others of, one, how our team operates, how it was instituted, and the outcomes of patients that we've had so far. And again, the hopes is to spread more knowledge of the potential benefit of having such teams. There are over now 50 PE response teams, and the number is rapidly growing. Like I said, Brigham and Women's Hospital has seen over 300 patients in the last several years. There's something called the PE Response Team Consortium that was started out of Mass General Hospital and helps brings all these teams together in a coordinated effort once a year for a meeting to discuss optimal management of pulmonary embolism with goals of also doing further research, as I had mentioned, to promote the care of patients with pulmonary embolism. It's pretty unique and has taken off quite dramatically in just a few years. So that's all I have. I hope that gives you a little bit of an overview of pulmonary embolism teams, what we feel the hopeful benefit is to patients, and I think should be something that will be popping up even more around the country. Happy to take any questions you guys may have.
Thanks, Dr. Carroll. That was a really thorough introduction and overview of PERT teams. We have gotten several questions in over the chat, so I will go ahead and get started with those. The first one is there a way to find out if a hospital has a PERT team? Is there a central list somewhere?
So I know the Pulmonary Embolism Response Team Consortium, the PERT Consortium, which is kind of listed here. If you look up their website, they'll have a listing of institutions that are part of the consortium. That being said, the consortium is an organization in itself. So a hospital may have a pulmonary embolism response team, but may not be part of the consortium. So this isn't an exhaustive list, but it will at least give you a list of some hospitals that certainly do have a PE response team. You could try just calling the hospital as well or looking online based on their website, but there's no exhaustive list outside of this consortium that I know about.
Okay, thank you. The next one, this is an interesting question. Is there ever a problem of having too many cooks in the kitchen with PERT teams? And if so, who has the deciding vote?
That's a great question and something we were afraid of when we first started the team. So I think you certainly can have too many cooks because if you have too many differing opinions, no matter what the circumstances, it can be difficult to come up with a consensus. Fortunately for the team, the way it works at Beth Israel is that there's really only one or two specialists from each specialty. So there's really only 10 or 12 members of the team. So we get to know each other pretty well. And overall, there's pretty good agreement because we have a sense of what everyone is thinking before we even have the conversation, given that we have a fair amount of experience now. I know at some centers, they may have 10 or 15 people on the call because it's kind of the cool and fun thing to do now with the new PE teams. But in doing so, I can imagine those teams have a little bit of trouble coming with a consensus. Ultimately, for the PE team at Beth Israel and at Brigham Women's Hospital, it's the attending of record. So the attending specialist that will see the patient in person that has the final say. So at Beth Israel, it's the cardiologist. At Brigham Women's, it will change depending on the week of who's on call. But they're ultimately responsible for making the final decision. But you're right, there can be some trick where there'll be a conversation that's 10 or 15 minutes on a patient, and then there'll be others that are 30 or 45 minutes because there's a lot of back and forth of what may be best.
Interesting. Are PERT teams customizable? For example, if a patient comes in with an active cancer, would an oncologist be consulted as well?
Yeah, so they are customizable, and different institutions work differently. At Beth Israel, and really anywhere that uses a similar program, you can call in any specialist to be added on to the team. So we've had a couple of cases where not so much an oncologist, because our hematologist on the call is also an oncologist, so he has a lot of background in that area, but we certainly do see a fair amount of patients with cancer, as pulmonary embolism and cancer go hand in hand, unfortunately. But we'll have a case where a patient had a recent surgery. They're coming in 2 or 3 weeks after a knee surgery or a brain surgery, or they have some other issue that is pertinent. We've had a pregnant patient, so we had the obstetrician on the call. We'll have the surgeon that did the surgery 3 weeks prior on the call, so we can discuss what the real bleeding risk is if we do one of our more advanced therapies. And it really helps bring a nice continuity to a patient's care. There are other cases where it's relatively straightforward and we don't need the cardiac surgeon, or we feel like we don't need the hematologist in that particular case. So we can also customize it to make it smaller as well if needed. So there's a lot of variability, but the mechanisms need to be in place in a particular institution, and the understanding that a PERT team is there to promote the benefit of the patient. So that the attendings that may not be on the call regularly, the spine surgeon, for example, is aware of the team and is willing to be on the team so they understand we're trying to really expedite the care and coordinate the care of the patient.
Excellent. Has there been any research done yet into how PERT teams improve, the outcomes in patients?
No, that's a great question. And there's a lot of projects up in the air. Currently, one based out of the PE response team consortium and something that we're developing at Beth Israel Deaconess Medical Center. However, it's been tricky and because it's still early. Most of the teams have only been around for a couple, maybe 2, 3, 4 years at most. So it's been difficult to compare quite yet. But I know there are plans to look at the benefits in terms of how long the patients are in the hospital, what kind of. It's been difficult to compare quite yet, but I know there are plans to look at the benefits in terms of how long the patients are in the hospital, what kind of treatments they're receiving, bleeding, and overall survival with PE teams. But that just hasn't been done yet because the teams needed enough initial experience in patient numbers to do that comparison. But I know that is in the works, and
we'll have to see. It certainly makes us feel good that we think we're helping the patient because we're coordinating care and we feel like we're bringing all the experts together. But it's a good question because sometimes things may feel good or seem right, but ultimately they may be not of great benefit. But I think with time we'll see that this is probably the best way to go, or that's my hope at least.
Okay. If I have a family member or a friend who is in the hospital and they do not have a PERT team, should I ask them to be seen by multiple specialties?
Yeah, that's a tough question. So it will depend on the particular institution. Some may have for example, a vascular medicine specialist that is that's also a cardiologist that has a good background in hematology, or maybe there will be a particular pulmonologist that's an expert in pulmonary embolism. So it's tough to know what a particular institution has. It's not unreasonable to at least ask if they feel like that would be of use. You can also ask if there's any partner institution. There are a lot of large networks now, so small community hospitals are affiliated with larger hospitals, and their larger hospital may have a PE response team. And we've done a few calls for our affiliates in the community over the phone, and then that will help decide whether or not a patient needs to come into the big city for further evaluation.
Okay. This is a good question, too. So it seems like PERT teams are great for when a patient, comes into the hospital with a PE, but how do you recommend a patient follow up with his or her PERT team after hospital discharge?
Yeah, that is a great question. And different institutions that differ here as well. So at Beth Israel, the way it works is that a patient will be assigned to a member of the PE team in follow-up. So if they have particular needs within cardiology, they'll be seen by the cardiologist. If they have particular needs within pulmonology, they'll see the pulmonologist. If they have a real complicated clotting mechanism or it's tricky to figure out what blood thinner they should be on, more so than usual, they'll see a hematologist. And that person will kind of help drive the bus. Sometimes they'll see multiple of those providers. At other institutions, for example, at Mass General Hospital, they have a multidisciplinary clinic where you'll be seen by one physician, but they'll all talk about you similar to how they would as if you were in the hospital. At Brigham and Women's Hospital, there is a vascular medicine specialist who are knowledgeable in both cardiac care and blood clotting disorders. So they're kind of the uniform. So it will depend on the institution, but if there is a goal within the PE consortium, PERT consortium, that there is a mechanism in place. So patients are seen in follow-up as well, because as many of you know, it's not just the acute care. That's what we, certainly urgent, but it's also the long-term chronic care that's so important in pulmonary embolism.
Okay. Do patients who are seen by a PERT team, do they tend to get more aggressive or less aggressive?
That's a great question. It's been a concern of some. For example, the pulmonologists have traditionally been more conservative, or the hematologists, where the interventional radiologist or the interventional cardiologist may be a little bit more aggressive because they're the ones that do the procedure and in terms of putting in catheters that may help break up the clot. So there's been some concern if that the team is driven primarily by one of those specialties, they may be doing more procedures. In our study and the one, there was a large study done at Mass General as well, there was no increased rate from the traditional therapies or the traditional rates of those technologies. That being said, it's a little difficult to know quite yet because these new technologies are so new. Many have only been implemented since a PE team has been around. What I will say about having a multidisciplinary team is that when you have a hematologist and a pulmonologist on the call as well, the goal is to get a balanced recommendation. So maybe the interventional radiologist is leaning towards doing a procedure and the hematologist is leaning more towards just doing a blood thinner. That's where a conversation with the 3 or 4 specialists on the call can really help come to a consensus. So I think there hasn't been, at least in my experience, an overuse with the goal. As with any new technologies, we're still learning how best to use it, but I think we're trying to come up with balanced recommendations.
Great. How would you stratify treatment for an unstable patient with no contraindications? Catheter, thromboectomy, or TPA, and are there any recent recommendations?
Yeah, so this has been a lot of conversations in our team because often we're seeing sick patients that are somewhere in the middle. So they certainly have high-risk features but may not be the classic quote-unquote massive pulmonary embolism. Patients that meet that classic criteria, it's still recommended that they get the IV clotbuster TPA. So that's traditionally what we're doing. And those patients that are kind of more teetering on the edge, they don't have quite the massive pulmonary embolism, but have a lot of concerning features, we're leaning towards more the catheter-directed therapy because they can get a lower dose of the clotbuster with a theoretical lower risk of bleeding. Unfortunately, what happens frequently in our cases is that the patients have some comorbidity, some other condition that puts them at high risk for bleeding, whether it be cancer or they've had a recent bleeding in their stomach or have recent chemotherapy, that the decision becomes a little more difficult where we're leaning more towards the catheter-based therapy, again, because of the theoretical lower risk of bleeding with the lower total dose of the clotbuster.
Okay, excellent. Kind of a more general question that gets asked. What advice do you have for patients just diagnosed with a pulmonary embolism?
So I think it's important to have early follow-up with a physician, whether it's your primary care doctor or a specialist, to help guide and make sure you're on the right blood thinner for you, because there's a lot of different options that have come up over the last several years. So it's important to make sure you're on the right blood thinner and that you're tolerating it appropriately and you're having any necessary lab work to make sure that it's a safe medication for you to be on. I think it's important to understand that you're on a blood thinner now and the appropriate measures of things to watch out for bleeding, not doing any risky behavior like skiing or playing contact sports or anything out of the ordinary. You can certainly lead a regular life, and I think it's important to stay active once you kind of get back on your feet. But I certainly wouldn't be, or at least try not to be too down about the fact that you may feel a little tired or fatigued, winded for a few weeks to even months sometimes before you get back completely on your feet, and that will take time. So it's okay to take it easy initially, but with time you'll get back to where you were in many cases. And if you don't, by a month or two, you can certainly touch back with your local PE expert to help guide if there's anything further in terms of evaluation that needs to be done. But I'm sure it's a scary event initially, but often you get back on your feet with some time and some help from the right providers.
Okay, great. So that was, we had a lot of great questions, and that was, I think, all of them. So I think we're going to go ahead and wrap up. Dr. Carroll, any final words?
No, I don't think so. I don't have any direct contact with NATF in terms of my email address being available, but certainly if anyone has any questions that come up, I'm happy to talk. You can reach out to Catherine, and she can get in touch with me. I think a PE team is a great idea. I would say, though, if you happen to go to an institution that doesn't have one, it doesn't mean you're not going to get great PE care. It's just a different approach currently, and we'll see where things go. But I appreciate all the questions. Those were very thoughtful questions of a lot of things that we've struggled with the initiation of these teams, and I think are slowly improving for everybody.
Excellent. Thank you. So we are going to go ahead and wrap up for today. Our next online support group is going to be on October 4th with Dr. Vincent Pellegrini at the Medical University of South Carolina in Charleston. And he is an orthopedic surgeon, and he's going to be talking with us about the PERT trial, which is preventing blood clots in patients who've undergone hip and knee replacements, as well as anticoagulation strategies for patients who are undergoing surgery. So we've gotten a lot of questions about this, so this should be a pretty hot topic. And we look forward to having everyone. Again, Dr. Carroll, thank you so much. This was terrific.